in our routine practice, like rheumatoid arthritis, ankylosing spondylitis, systemic lupus erythematosus, scleroderma, and this psoriatic arthritis. These are also very common. But most of the people, they don't know that they are living with the, without knowing that they are living with the psoriatic arthritis. Next one. Okay. See, it's again a chronic one, it's a progressive and inflammatory and autoimmune. A chronic, progressive, inflammatory, autoimmune disorder of the joints as well as the skin. So, dermatological manifestations. Characterized by osteolysis and the bony proliferation. Here you will have both bony destruction will be here, seen by your narrowing of the digits, etc. And also the new bone formation is also common, syndesmophytes. Okay, new bone formation. So there will be the osteolysis, erosions. On the other hand, they will have the bony proliferation or enlargement of the bones. So the clinical manifestations include dactylitis, enthesitis, osteoperiosteitis, large joint oligoarthritis, mostly the oligoarthritis here. So I told you, monoarthritis, oligoarthritis, polyarthritis. Mono single joint, oligoarthritis 2 to 4 joints, 5 or more than the 5 is polyarthritis. Here the psoriatic arthritis is mostly the oligoarthritis. Arthritis mutilans, sacroiliitis, spondylitis and distal interphalangeal arthritis. So these are very, very common presentations in the psoriatic arthritis. So distal interphalangeal joints, only the two cases, two reasons. One is psoriasis, another one is osteoarthritis. Whereas the proximal interphalangeal joints, rheumatoid arthritis. Okay. Here the sacroiliitis is a very common in ankylosing spondylitis. That is bilateral. Whereas in the psoriatic sacroiliitis, usually the unilateral. And you will have the spondylitis. So these people will have the backache also. Axial skeletal involvement in the psoriatic arthritis, like your ankylosing spondylitis. But there it is HLA-B27 is strongly positive there. Here that is not that much positive, but some people may have HLA-B27 positive in psoriatic arthritis also. Okay. So these people will have the dactylitis and enthesitis. So that is the inflammation of the tendons entering, okay, and the ligaments, bursa. So these are the very common in psoriatic arthritis. And osteoperiosteitis, large joints involvement. And psoriatic arthritis is one of a group of the disorders known as the spondyloarthropathies. So I told you these are all spondyloarthritis, you will have the rheumatoid factor negativity. So RA factor will be the negative here. So the common examples for these spondyloarthropathies are ankylosing spondylitis, psoriatic arthritis, and arthritis due to the inflammatory bowel diseases like your Crohn's disease or the ulcerative colitis, and sometimes undifferentiated spondyloarthritis. Here the males and the females are equally affected, 1:1 in psoriatic arthritis. Psoriatic arthritis can range from the mild, non-destructive disease in some population to severely rapid and destructive arthropathy in some population. So it is on one hand it is a mild disease, on the other hand it is a very, very severe and aggressive disease and a destructive disease also. Usually rheumatoid factor negative here in psoriatic arthritis, and X-ray changes can be noted in up to 47% of the patients at a median interval of the 2 years despite the clinical improvement with the standard DMRD therapy. Okay. So these people will have a radiological damages. So whether your X-rays or an MRI, you will find these radiological damages in nearly the 50% of the patients within 2 years of the disease onset, despite the clinical improvement with the standard DMRD therapy. So standard DMRD therapy like your hydroxychloroquine or your methotrexate or leflunomide or sulfasalazine, they give good improvement, clinical improvement, but radiological improvement will not be there in almost all the cases. But in 50% of the cases, even though the clinical improvement is there, the radiological destruction in the joints will be there. So those people better to use the biologicals to avoid the radiographic damage. So these are the groups. See, the ankylosing spondylitis is the prime disease in the group of your spondyloarthropathies, and you will have the PSA, that is psoriatic arthritis. Reactive arthritis, that is also very common following the viral infections. See, following the gastroenteritis, these people will have, and following chikungunya. Okay, they are the reactive arthritis. And arthritis associated with the IBS, juvenile spondyloarthritis. So they are the young people, they present with the spondyloarthritis. And sometimes it is undifferentiated spondyloarthritis. Even on the day one, we cannot diagnose it the spondyloarthritis. Either it is ankylosing spondylitis or psoriasis or react, etc. And your diagnosis at that juncture is undifferentiated. But in due course, they will come, they will land up with ankylosing or psoriatic or the reactive or the juvenile, etc. The prevalence of this spondyloarthritis is comparable to that of the RA. 0.5 to 1.9% is a very common in males, ankylosing spondylitis, and psoriatic arthritis, both male and the females are equally distributed. It affects 2% of the population, psoriasis. So it's a very big disease for a rheumatologist, for a physicians. Okay, 7% to 42% of the patients with psoriasis will develop the arthritis. Not all population, but very good number of the people develop arthritis. See the 2% of the population. If you see the 50% of the psoriatic population, that means 1% of the population. 1% of 140 crores of the Indians. So don't underestimate a psoriatic arthritis in our society. This arthritis is a chronic one and an inflammatory, autoimmune. It is also the skin psoriasis, usually rheumatoid factor negative, and also your CCP, anti-CCP is also negative. That is a distinct from the rheumatoid arthritis. It is classified as one of the subtypes of these arthropathies, characterized by synovitis, enthesitis, dactylitis, spondylitis, skin and the nail psoriasis. So skin changes, nail changes. The skin sometimes on the sole of the foot. Nowhere in the body these people will have the psoriasis. The psoriasis patch will be on the sole of the feet. So you have to examine the feet very sole is also one should be examined to rule out the psoriasis. In the same way, some people will have on the head psoriasis capitis. So these are also very common. And the nail changes is a very common in psoriatic arthritis. See here. See the nail changes there. So this is the dactylitis. Right upper is the dactylitis. Okay. Left lower, psoriasis of the body, entire body. And right lower, so this is the enthesitis. Okay, tendilis Achilles. So these are the pictures. So you should remember these pictures. So if you remember these things, definitely you can diagnose as the psoriatic arthritis. So this is, what is this? Chiranjeevi, right upper, dactylitis. Right lower, enthesitis. So tendon Achilles enthesitis. And these two, left upper one is nail changes. See the nail changes. Okay, in the index finger. Okay, on the right eye, right hand, second, third, and fourth, very nail involved. Okay, and also you can see the psoriatic patches on the knuckles here, and of course, left lower is a beautiful psoriasis on the body. Esara print అయిపోయిందా brain లో print కొట్టావా right. So the epidemiology, incidence Europe and the North America about 3 to 23 cases in 10 to the power of 5 and 10 1 lakh population. Okay. In Japan 0.1 case. So you need not remember these cases, but India is very common, very common. The prevalence of the psoriatic arthritis is assumed to be larger than the expected. That is the more important. So as a physicians, we should diagnose the psoriatic arthritis in almost all the cases. We should not miss the diagnosis of psoriatic arthritis. It is larger than you were expected. Since enthesitis associated with psoriatic arthritis can develop without the symptoms or the signs that are recognizable by the patients themselves or the physicians. Okay. So some genetic, so like all other autoimmune diseases, some genetic factors and immunological factors and environmental factors. Trauma, this is a Koebner's phenomenon. Psoriatic lesions arising at the site of the trauma, development of psoriatic arthritis after trauma to the joint. So the trauma is a common environmental factor to cause the psoriasis. So the bacterial infections, association between the gut-aid psoriasis and streptococcal pharyngitis. Up to 30% of the psoriatic arthritis synovial tissue derived the T cells proliferate following the exposure to the group A streptococci. What are the genetic factors? It is known to occur in families, so runs in the family. So strong family history is very important. Not only the personal history of the psoriasis or the past history of the psoriasis, and the family history of the psoriasis is also important to diagnose the psoriatic arthritis. Up to 40% of the psoriatics or the psoriatic arthritis have a family history in the first degree relative. 50 times more likely to occur in the first degree relatives than the controls. It is more in the monozygotic twins and more commonly than the dizygotic twins. See, in the twins, monozygotic 35 to 70% and 12 to 20% for the dizygotic twins. HLA-B 27, as I told you, like your ankylosing spondylitis, here also it will be positive in some population. In the presence of HLA-DR7, DQ3, HLA-B27 less than ankylosing spondylitis are the raters. Some psoriasis and spondyloarthritis are HLA-B27 negative. Psoriatic arthritis and HLA-B27 who do not have the spondyloarthritis, some population. So even though they have the psoriasis, even though they have the HLA-B27 positive, so some people they may not have the arthritis also. So some patients with HLA-DR4, psoriatic arthritis with polyarthritis, like your rheumatoid arthritis, so they present like a polyarthritis, not like a oligoarthritis. Oligoarthritis is very common in psoriatic arthritis. So those people with HLA-DR4, so they present with polyarthritis rather than the oligoarthritis. What is the role of the tumor necrosis factor? It is released predominantly by the cells of the monocyte or the macrophage lineage, accumulation of the T cells, infiltration of the synovium, TNF mediated production of the factors that attract the T cells, monocyte chemoattractant protein 1 and macrophage inflammatory protein 3 alpha. It induces the lymphocyte and the neutrophil migration into the synovium. High levels of the TNF alpha in the psoriatic synovium, psoriatic arthritis synovium. So if you examine the synovium in the psoriatic arthritis population, so you will find high levels of the TNF alpha. Inflammation of the synovium, enthesis and the bone. I told you the bone in the two ways. One is the bone destruction will be there and the bone formation will be there in psoriasis. So the bone destruction in the tumor necrosis factor alpha transgenic mice, it promotes the release of the matrix degrading metalloproteinases, enhances the secretion of the pro-inflammatory cytokines like your interleukin 1, 6 and 8. It also potentiates the osteoclastic bone resorption. See the metacarpophalangeal joints involvement, not the proximal interphalangeal joints, but here the distal interphalangeal joints, especially the middle finger and also in the index finger. So you will have a proximal interphalangeal joint involvement and also the metacarpophalangeal joint involvement without any proximal interphalangeal joints involvement, and you will have a psoriatic patches here on the fingers. So the differential diagnosis, when you diagnose with the rheumatoid arthritis, you know that rheumatoid arthritis is a symmetric one, whereas the psoriatic arthritis is asymmetrical. Here the proximal interphalangeal joints, metacarpophalangeal joints, not the distal, in the rheumatoid arthritis, whereas in the psoriatic arthritis, not the PIP but the DIP. Ulnar deviation is very common in rheumatoid arthritis. We have seen, I have shown you some pictures, ulnar deviation, and also swan neck deformities. And nodules will be there, that is the rheumatoid nodules. When the rheumatoid nodules are positive, the disease is aggressive, and you need to use the DMRDs at higher dosages, and also the biologicals in those people who are having the rheumatoid nodules positivity, because they will be present with more autoimmune diseases. And the common diagnosis is the ankylosing spondylitis, a differential diagnosis when the fellow is presenting with the backache or sacroiliitis or spondylitis. So how to differentiate from the psoriatic arthritis here? Here ankylosing spondylitis is a strong HLA-B27 association, a male predominance in ankylosing spondylitis, where the psoriatic arthritis male and female are equal. It is the axial skeletal involvement. Most of the sacroiliitis, it is the bilateral sacroiliitis, whereas the psoriatic arthritis, it is a unilateral sacroiliitis. Bamboo spine is very common in ankylosing spondylitis, not in psoriatic arthritis. In psoriatic arthritis, you will have the bone resorption is also there, bone destruction will be there, erosions will be there. And Scober test demonstrating the limited flexion. I told you this Scober's test in ankylosing spondylitis. So that is how you differentiate the psoriatic arthritis from rheumatoid arthritis and ankylosing spondylitis. So these are the important features of the rheumatoid arthritis. These are the important features of the ankylosing spondylitis. So if you remember these things, you can diagnose the rheumatoid arthritis and also ankylosing spondylitis, and you can rule out the psoriatic arthritis. And if your patient is not entering into these two criteria, and then definitely a psoriatic arthritis is the one possibility in your own patient. See here, I told you the soles of the feet. See here the pitting, infectious agents, Shigella, Salmonella, Yersinia, Campylobacter, Chlamydia, triad, urethritis, conjunctivitis, arthritis, keratoderma, blennerasicum. So these are the different raters, basets, etc. How to diagnose the psoriatic arthritis? What is the criteria of the psoriatic arthritis? So how all these rheumatological diseases, you will have a criteria. I told you the criteria for the rheumatoid arthritis. I told you the criteria for the lupus. I also told you the criteria for your Sjogren's. Now the criteria for the psoriatic arthritis. So the classical description of the psoriatic arthritis using the diagnostic criteria of Moll and Wright. So these two people, they have given us a criteria named after Moll and Wright, including 5 clinical patterns. So what are they? One is asymmetric mono or oligoarthritis. It is an asymmetric, either the monoarthritis or oligoarthritis. And the second group is symmetric polyarthritis. And the third group is distal interphalangeal joint involvement. And the fourth one is axial, that is your spondylitis and sacroiliitis. And the last one is the arthritis mutilans. Arthritis mutilans. Okay. See, they have given the pictures also here. The first one is asymmetric monoarthritis. So the mostly the joint of the left knee joint is involved here. Right is the normal, left is abnormal in the first picture. And the second picture, it is a symmetric polyarthritis. All the joints are involved. The third picture is the distal interphalangeal joints. Okay, see the nail changes also here. And the fourth picture, it is the axial spondylitis and sacroiliitis. Okay, and the fifth one is the arthritis mutilans. Here this is arthritis mutilans. However, the patterns may change over the time and are therefore not useful for the classification. So today you are seeing a case of the symmetric mono or oligoarthritis. In the next 6 months they turn up into the symmetric polyarthritis, or maybe with axial involvement, or finally arthritis mutilans. So we can talk something about the asymmetrical oligoarticular arthritis. Is a very common in psoriatic arthritis. It is the most common type. Nearly the 70% of the population will have asymmetrical oligoarthritis. Asymmetrical, similar to the low-grade gout. Gout is also present like that, but the gout is mostly the metatarsal joints there. Mostly a single joint involvement in the gout. But in sometimes gout also can present as a oligoarthritis. Sometimes gout also presents like a polyarthritis. I have seen 2 cases of the gout with almost all the joints are involved, like your rheumatoid arthritis. Okay, so that is also there. The gouty sausage-like swelling of the tophaceous coat. Sausage-like swelling of one or the more digit, that is the dactylitis. I have shown you the picture there now. So that is here. Sausage-like swelling of the one or more digit. That is the total digit is involved here. That is the dactylitis. A large joint such as the knee is also common involved in the earlier first picture, knee joint involvement. And usually less than the 5 joints are affected at any one time. That is oligoarthritis. 5 or more than the 5 is the polyarthritis. Enthesitis, flexure sheath synovitis. So these are the common in psoriatic arthritis. See the psoriatic patches here also. What are the hallmark clinical features in the psoriatic arthritis? So, dactylitis and enthesitis. So, without the dactylitis and enthesitis, so our diagnosis of the psoriatic arthritis is a big dilemma. So, you are not sure without the dactylitis and enthesitis the diagnosis of the psoriatic arthritis, even though it is a oligoarthritis, even though it is an asymmetrical. So, without the nine involvement, without the dactylitis and enthesitis, or without the skin involvement, so the diagnosis of the psoriatic arthritis is not possible in majority of the cases. So this is the typical dactylitis. What you mean by dactylitis? A diffuse swelling of the digit may be acute with painful inflammatory changes, or sometimes it may be chronic, wherein the digit remains the swollen despite the disappearance of the acute inflammation. So in the chronic arthritis, even though the swelling will be there, the patient is not having any pain, so the painless swelling will be there. Whereas in acute, so that is the painful. A painful inflammatory changes in the acute dactylitis. So what is this? Is this acute dactylitis or chronic dactylitis? Most probably the chronic dactylitis. Okay. It is also referred to as sausage digit. Recognized as one of the cardinal features of the psoriatic arthritis. So another cardinal feature is enthesitis. So the dactylitis is one of the cardinal features. What are the other cardinal feature is? Enthesitis. Good. Occurring in up to 40% of the patients. Feet most commonly affected. In psoriatic arthritis, mostly the feet is commonly involved, like your gouty arthritis. Dactylitis involved the digits show more radiographic damage. So if you get an X-ray here, then you can see the erosions, bone destruction, and narrowing of the bone, so your periosteoitis, and also new bone formation, syndesmophytes. So these are all we'll see in the radiological features. So you can appreciate here. So this is the enthesitis on the right foot. Entheses are the regions at which a tendon or a ligament or a joint capsule attaches to the bone. That is the enthesis. The region at which a tendon or a ligament or a joint capsule attaches to the bone is the enthesis. This inflammation of the enthesis is called enthesitis. This is very common in psoriatic arthritis along with the dactylitis. So dactylitis is sausage-shaped digits, mostly the feet. Inflammation at the enthesis is called enthesitis, and again a hallmark of the psoriatic arthritis. So pathogenesis not fully known. Isolated peripheral enthesitis may be the only rheumatological sign of psoriatic arthritis in a subset of the patients. So sometimes when the patient presents with this only, then you can examine thoroughly, you can find some psoriatic patches somewhere in the body. Then what is your diagnosis here? It is psoriatic enthesitis, psoriatic arthritis. Okay. So unless you examine the skin thoroughly for the search of your psoriatic patches, so you are going to miss the diagnosis. Your diagnosis may be the tendon nucleus. What is the etiology? So etiology here is the psoriatic arthritis. It is a symmetrical polyarthritis like your rheumatoid arthritis or your lupus, etc. It is a rheumatoid-like pattern in 15% of the cases, whereas asymmetrical oligoarthritis 70% of the cases. Psoriatic arthritis, asymmetrical oligoarthritis 75%. Symmetrical polyarthritis is also possible in 15% of the cases. Hands, wrist, ankles and the feet may be involved. So differential diagnosis of rheumatoid arthritis. So what are the features? Even though it is a symmetrical polyarthritis, how will you confirm the psoriatic arthritis? Because DIP joint involvement here. Whereas in rheumatoid arthritis, it is the proximal interphalangeal joints. Morning stiffness. Again in the rheumatoid arthritis also you will have a morning stiffness. Fusiform deformity, windswept deformity, relative asymmetry. Subcutaneous nodules are absent in the psoriatic arthritis, whereas the positive in the rheumatoid arthritis, that is rheumatoid nodules. Rheumatoid factor will be the negative here, that will be the positive in rheumatoid arthritis, or anti-CCP antibodies will be negative here, positive in rheumatoid arthritis, and mild with less deformity. More deformities, aggressive in rheumatoid arthritis. In psoriatic arthritis, the disease is mild with less deformity. And ulnar deviation is a very common in rheumatoid arthritis. Here the distal interphalangeal arthropathy is a classical form, less common in 16% of the population. Involvement of the nail with significant inflammation of the paronychia and swelling of the distal tuft may be the prominent. 30 pits with inflammatory arthritis of the DAP joint is considered the diagnosis. That is the most important things. So you have to count the pits. There will be the more than the 30 pits in a single nail. So that is your psoriatic arthritis. And arthritis of distal interphalangeal joints. You need not count the pits, but immediately you can see whether they are about 20 or 30 or 40 or 50. So if the distal interphalangeal joints are involved and no diagnosis other than the psoriatic arthritis, you need not count the pits also. Okay, just your examination will tell you. So this is the psoriatic arthritis because of the distal interphalangeal joints involvement and the pits in the nails. See here the psoriatic arthritis involving the distal interphalangeal joints here. See the joints here. See the penicillin cuff. Penicillin cup. Especially the third finger, you can appreciate the distal interphalangeal joints here. In the fourth one, you can appreciate the narrowing of the joints there. And distal interphalangeal joints here. See, this is the arthritis mutilans. This is a rare form, maybe 1 to 5% of the patients. Some reports suggest up to the 16% of the patients. But in my practice, I have not seen even the 0.5% in my own patients. Resorption of the bone, that is osteolysis, with the dissolution of the joint is observed as the penicillin cup radiographic finding and leads to the redundant overlying skin with the telescoping motion of the digit. So this is a very common finding we appreciate in the X-rays. So you need not see the report also from the radiologist. So in experience, you can diagnose this penicillin cup radiographic findings. This opera glass hand is male more than the females and is more frequent in the early onset disease. See, this is the arthritis mutilans. See how dangerous it is, more common in the males. Penicillin cup radiographic changes here. See the here, you can appreciate in the thumb, penicillin cup, okay, the thumb here, even in the index finger also in the upper photo. Spondylitis with or without the sacroiliitis. 5% of the patients and has a male predominance, can occur in conjunction with other subgroups of the psoriatic arthritis. Spondylitis may occur without the radiographic evidence of the sacroiliitis, which frequently tends to be asymmetrical. May appear radiologically without the classic symptoms of morning stiffness in the lower back. The correlation between the symptoms and the radiological signs of the sacroiliitis can be poor. Vertebral involvement differ from that observed in the ankylosing spondylitis. What will be the vertebral involvement in ankylosing spondylitis? Bamboo spine. Okay, so that is not there in psoriatic arthritis. But psoriatic arthritis people can present with the backache like the spondylitis. So the drugs Diamide is more useful at this juncture are the sulfasalazine. So sulfasalazine acts better in the people with the axial symptoms. See here, the vertebra are affected asymmetrically and the atlantoaxial joint may be involved with the erosion of the odontoid and subluxation with attendant neurological complications. The same atlantoaxial joint will be involved in the rheumatoid arthritis also. No other joint in the spine, cervical spine, except the atlantoaxial joint involvement in the rheumatoid arthritis. Therapy may limit the subluxation associated disability, unusual radiologic features, non-marginal symmetrical syndesmophytes. So this is the lateral X-ray of the cervical spine. Syndesmophytes are the C2 and C3 and C6 and C7. Patterns may change over time and are therefore not useful for the classification. See, these are the patterns you see in the psoriatic arthritis. So the monoarthritis. So monoarthritis may remain as monoarthritis or no clinical evidence of the joint disease. Suppose oligoarthritis. So oligoarthritis, some joint changes may reduce to become the monoarthritis or may remain as oligoarthritis, or more and more joints involved can turn into the polyarthritis. Some people, the spondyloarthritis is a common in oligoarthritis also. So these are the different pictures. DIP, so remain as the DIP. So polyarthritis, again the polyarthritis, oligoarthritis are mutilants. Spondyloarthritis, mutilants. So these are the clinical patterns. So mono, oligo, poly. Not only that, distal influenza joints involvement, spinal involvement, and arthritis mutilants. So this is the Caspar criteria for the classification of psoriatic arthritis. So inflammatory articular disease, the joint or the spine or emphasis, with more than 3 points from the following categories. In psoriasis, any current history, current psoriasis, if the patient is having a psoriatic patch on the body, you can give the 2 points there. And if the past history, 1 point. A family history, 1 point. Okay. Nail dystrophy is there, you can give 1 point there. And rheumatoid factor is negative. So negative is a 1 point. If the positive, we don't give any point there. And dactylitis. And present dactylitis, 1 point. Even history of the dactylitis is also there. You can give a single point. It is recorded by a physician or a rheumatologist like you. Radiographs, hand or the foot, evidence of the juxtaarticular new bone formation. So I told you, the bone destruction will be there, and also the new bone formation is also will be there. So here the specificity 98 and sensitivity 91%. So this is the criteria. The name given to this criteria is Caspar criteria for the classification of psoriatic arthritis. So it is an inflammatory articular disease where the inflammation, the joint, the spine and emphasis. This psoriatic arthritis. Whereas in ankylosing spondylitis, it is also inflammatory articular disease, but where it is mostly in the spine. In rheumatoid arthritis is also an inflammatory arthritis, where it is more common in the metacarpophalangeal joints and the proximal interphalangeal joints. Okay, so when the emphasis are involved, is the psoriatic arthritis. With more than the 3 points from the following categories, the psoriasis. So the current or past history and the family history. So here even with the family history of the psoriasis also you can add 1 point here. Nail dystrophy, rheumatoid factor negative, dactylitis and X-ray. So without an X-ray also we can gain 3 points. Suppose if the patient is having the current psoriatic patch on the body, you are giving 2 points there. Nail involvement is there, some pits are there, so it is 1 point, that is sufficient. Psoriatic patch and the nail pits, and when the fellow is having some arthritis, so your diagnosis of psoriatic arthritis is confirmed, and obviously rheumatoid factor will be the negative there, so that way again one more point for you. Signs and the symptoms. So the morning stiffness lasting more than the 30 minutes in 50% of the patients. So in all the autoimmune diseases, so usually the morning stiffness will be there. More than the 30 minutes is very common in our Indian population. If you see the Western population, the morning stiffness will be more than 1 hour there. Okay. Ridging, pitting of the nails, ankylosing up to 90% of the patients versus the nail changes in only 40% of the psoriatic patients. Patients may present with a less joint tenderness than is usually seen in the rheumatoid arthritis. Rheumatoid arthritis, joint tenderness is very, very high, whereas in psoriatic arthritis is not that tender when compared to the rheumatoid arthritis. But dactylitis may be seen in more than 40% of the cases, maybe 60-70% of the patients will have a dactylitis. Eye inflammation like the conjunctivitis, iritis or uveitis maybe 7 to 33% of the cases. So again, the eye involvement is a very common in autoimmune diseases like ankylosing spondylitis is a very common. Psoriatic arthritis about 7 to 33%. Rheumatoid arthritis, yes. Lupus, yes. Systemic sclerosis, yes. Mixed connective tissue disorders or progressive diseases. So again, eye involvement is very common. So we have a very good relations with our ophthalmology population, ophthalmology friends. In the same way, dermatology friends when you are dealing with the psoriatic arthritis. Uveitis shows a greater tendency to be the bilateral and the chronic when compared to the ankylosing spondylitis. Distal extremity swelling with a pitting edema has been reported in 20% of the patients as the first isolated manifestation of the psoriatic arthritis. Nothing, only the distal extremity swelling with pitting edema. So what I did is, when a swelling of the foot with the edema, maybe hypoalbuminemia, maybe heart failure, maybe the renal failure, or maybe the cirrhosis of the liver, etc., etc. But here it could be psoriatic arthritis also. So the distal extremity swelling with a pitting edema has been reported in 20% of the patients as the first isolated manifestation of psoriatic arthritis. So these are the main features of the psoriatic arthritis. The clinical psoriasis of the skin and the nails, peripheral arthritis, mostly the oligoarthritis, distal joint involvement, dactylitis and enthesopathy. The beautiful 5 points in psoriatic arthritis. So psoriasis of the skin and the nail changes, oligoarthritis, peripheral joints, distal interferon joints involvement, both dactylitis and enthesitis. You are dealing 100% a case of psoriatic arthritis. And rheumatoid factor will be the negative, and the anti-CCP will be the negative, and elevated acute phases like your ESR and CRP may be elevated maybe because of the secondary infections. Radiographics, you can see both the changes, destruction on one hand and bone formation, new bone formation on the other hand. So the erosions, desorptions, it is erosive arthropathy. And joint space narrowing, I have shown you the one picture there, and the disease, the narrowing is there. New bone growth at the enthesis. So you have syndesmophytes will be there, and sacroiliitis is also common in this psoriatic arthritis when they have a backache. So the main features and their frequency. So the DAP involvement may be 40%, nail psoriasis 80%, enthesopathy again the 40%, back involvement, the backache may be 50% of the cases, and the dactylitis may be 50% of the patients. So when you deal these 5 things, you should suspect the psoriatic arthritis wherever there is a DAP involvement, nail psoriasis, enthesopathy, dactylitis, and also the backache, that is your spondylitis. In 50% of the cases, usually it is unilateral, whereas in ankylosing spondylitis, a bilateral sacroiliitis is common there. Comorbidities in the psoriatic arthritis, the ocular inflammation. So already I told you the uveitis, episcleritis, scleritis, conjunctivitis, etc. In the IBD, your Crohn's disease or the ulcerative colitis. See the nail pitting, transverse depressions, and subingual hyperkeratosis. So these are very common psoriatic patches you see. So if you have any dermatology friends now, so please talk to them. So let them discuss something about their psoriatic skin lesions, so that you can be enlightened with the psoriatic arthritis much better. See the psoriatic patients, the psychosocial burden is a very common. So definitely their psychosocial burden with the psoriasis patients react to depression, higher suicidal tendency, and maybe alcoholism now is common, even the psoriasis and no psoriasis. Metabolic syndrome, hyperlipidemia, hypertension, insulin resistant, obesity, and diabetes, higher risk of cardiovascular disease because of the metabolic syndrome. See, the metabolic syndrome is also associated with the psoriatic psoriasis. So that's a new point to me today. Okay. So this is the staging of the psoriatic arthritis. So mild, moderate, and severe. Okay. So the peripheral joints, less than the 5 joints, no damage, no loss of function, quality of the life, minimal impact. So they are all the mild diseases. Okay. When it is very very severe, more than 5 joints damage and the quality of the life is impaired, that will be the severe. So you need not read all these things. But peripheral arthritis, so that is a mild, moderate and severe. Skin diseases, okay, spinal diseases, enthesitis, dactylitis, so mild, moderate and the severe. So what is the treatment? Interventions in psoriatic arthritis, a patient education is very important because they are very low in their education. Education is very important here. The physical and the occupational therapy, pharmacological interventions with your DMRDs, etc., reconstructive surgery and the rehabilitations. Pharmacological interventions, NSAIDs, as and when required, not for a long period. DMRDs, good drugs, anti-malarials, that is your hydroxychloroquine. Gold compounds we are not using now. Sulfasalazine, where the spinal involvement is there with backaches. Methotrexate, when the peripheral involvement and the peripheral joints are involved, or polyarthritis, we can use the methotrexate. Oral retinoids to tackle your metabolic syndrome or to reduce your cardiovascular risk. Immunosuppressive drugs like cyclosporin, azathioprine, when the lung involvement is also there, like ILD, etc. Steroids are very important drugs to be used in extensive diseases, but you should use as a bridge therapy. And some people, they may require the long-term steroid therapy also. You can use 5 milligrams or 10 milligrams of your prednisolone in such patients. And when you are using the steroids for a longer period, so better to add the calcium to avoid the osteoporosis, especially in the women. They are more prone for the osteoporosis in the menopausal period. Cytokine blockers like etanercept and infliximab. So these are the biological drugs. So these are also very. So in a single slide, so you can add, some people NSAIDs for a pain relief, and you can choose the DMRDs of your choice depending on the polyarthritis or the spinal involvement, etc. And the immunosuppressive drugs also depending on the extra articular involvements of these psoriatic arthritis, and of course cytokine blockers like etanercept and infliximab in some cases. So the methotrexate here maybe the 7.5 milligrams to the 25 milligrams per week. Usually use 10 milligrams, 15 milligrams, and we can uptitrate the dose to the 20 to 25 milligrams. But usually in 80% of the patients we use 15 mg of the methotrexate. Sulfasalazine, we start with 500 milligrams OD for first week, 500 milligrams BD for the second week, 500 milligrams TAD or 500 milligrams morning and 1000 milligrams night in the next third week, and 1000 milligrams morning and the evening BD in the fourth week, and thereafter you can continue the 2 grams. That's how we have to uptitrate the doses of the sulfasalazine. Leflunomide, nowadays we are not giving the loading doses of 100 milligrams per day for 3 days, but we are using the 10 milligrams every day. In some people we can uptitrate the dose to the 20 milligrams also. Hydroxychloroquine, usually we start with the 200 milligrams and you can go up to the 400 milligrams, but in a maintenance dose we always use the 200 or the 300 milligrams. Cyclosporin in some cases. Side effects, you all know that methotrexate have the nausea, fatigue, mouth ulcers, elevated LFT, elevated RFT. So that is the reason the people on the methotrexate, so the efficacy of the drugs in the psoriatic arthritis, see the NSAIDs, methotrexate, cyclophosphamide, and other DMRDs like sulfasalazine, etc. If you see the parameters of the psoriasis or the nail disease, peripheral arthritis, spondylitis, enthesitis, dactylitis, and extra-articular pain, these are the very, very important. So when choosing the particular drug, you should think of these things. When the fellow is having the more psoriatic practice, or the nail disease is the more, or the peripheral arthritis is the more, or spondylitis is the dominating one, or either the enthesitis or dactylitis, or some people are having extra-articular features. Accordingly, you can choose the drugs. For example, the NSAIDs. So when the patient is having the arthritis or the spondylitis, you can use the NSAIDs. But NSAIDs role in psoriasis is 0. NSAIDs role in nail diseases is 0. Where the NSAIDs in the role of extra-articular infections or the dactylitis and enthesitis is 0. So they have the role only in arthritis and the spondylitis. Suppose if you take the methotrexate, as I told you, it is very useful in the peripheral arthritis and the nail changes and the psoriasis. So some people know after your methotrexate introduction, the psoriasis also will come down. Okay. So some people I see the psoriatic arthritis population. When I initiate on the methotrexate, they feel very comfortable in the next visit. Doctor will reach drugs pain and psoriatic patches for the. So because the methotrexate will also act on the psoriatic patches. So that is a very important drug. Okay, and then the biological agents. See, biological agents will act on all the parameters. Biological agents like your infliximab or rituximab or etanercept, they reduce the psoriatic patch, they reduce the nail disease, they reduce the arthritis, they reduce the spondylitis, enthesitis, dactylitis, and the patients also have extraarticular features like uveitis or any lung infection, etc. So they also will be controlled. So our duty is use the NSAIDs as and when required to reduce the pain only, and use the steroids as a bridge therapy, use the methotrexate in some population, and use the sulfasalazine when the patient is predominantly with the spinal involvement, and if the patient can afford, so always choose the biological agents. Indications for the biological agents are psoriatic arthritis, extensive psoriasis, not responding to the phototherapy, your ultraviolet photosensitive therapy, phototherapy, retinoids, methotrexate, cyclosporine. So there is the indication to use the biological agents. So the mechanism of the action, dosing schedule, and major risks of the biological therapies. So the infliximab, the action is anti-tumor necrosis factor alpha. Etanercept, same. Adalimumab, anti-TNF, and rituximab, it is anti-CD20, B cell depletion. So the doses, so for example, now infliximab, 0 to 8 weeks and then once in 8 weeks. Etanercept, 25 milligrams bi-weekly, or usually we give 50 milligrams weekly. Okay, 50 milligrams weekly subcutaneously. So first are 2 shots, they come to us, and the third and the fourth shots every once in week, so they get their results. Etanercept. Okay. Adalimumab, so 40 milligrams once every 2 weeks. So once in 15 days we give the adalimumab. So that's how we have to give these drugs. Risks already told you, infections especially in tuberculosis. So before initiating these biologicals, we get the 3 tests done. One is MANTO, the second one is quantiferon gold, and the third one is CT test. So to rule out any latent tuberculosis. So there are different drugs. What are the other agents other than your disease modifying rheumatologic drugs and biologicals? Several other agents have been tried, including the vitamin D3, bromocriptine, fish oils, and their efficacy remains to be proven. So not totally proven. Anti-malarials, particularly hydroxychloroquine, are usually avoided in patients with psoriasis for fear of precipitating exfoliative dermatitis or exacerbating psoriasis. So that is a very take-home point. So hydroxychloroquine is usually avoided in patients with psoriasis for the fear of precipitating exfoliative dermatitis or exacerbating psoriasis. Some people, so they develop the dermatitis or increasing the psoriatic patches on your hydroxychloroquine therapy. So when you prescribe the hydroxychloroquine, you should think of these things. So size of the psoriatic patch on the day before the onset, before the introduction of your hydroxychloroquine. What about the patch size and the quality and the shape after your hydroxychloroquine therapy? So if the patch is increasing, or if the patient is having the disturbing symptoms of these psoriatic patches, so these are all because of the not the aggressiveness of the psoriasis, but because of your introduction of your hydroxychloroquine. 2 studies showed that these reactions did occur in patients who were treated with hydroxychloroquine. Therefore, this drug is occasionally used to treat the psoriatic arthritis. Steroids, systemic, usually avoided because of the possible rebound of the skin disease upon the withdrawal, and also for the fear of our diabetes, hypertension, osteoporosis, etc. Surgical care, arthroscopy, synovectomy in severe chronic and monoarticular synovitis, joint replacement or reconstructive surgery. So when the involvement of the knee joints, etc. Patients with severe pain or significant contractures may be referred for the possible surgical interventions. Hip and knee joint replacements have been successful. Arthroplasty in some population. So consultations and the monitoring the psoriatic arthritis. If the patient's physiatrist, that is what physiotherapist, feels uncomfortable with the prescribing medications for PA, refer to your rheumatologist with more experience with these agents may be advisable. Dietary considerations. So taking the NSAIDs with the food can reduce the stomach discomfort. Any NSAID can damage the mucus layer and cause ulcers and GI bleed when taken for the long periods. Cyclooxygenase 2 selective inhibitors are associated with the lower prevalence of the gastric ulcer formation. So usually we use the biological etc. in people who can afford more. So in such individuals definitely can prescribe the COX-2 inhibitors rather than your diclofenac or cyclophonac etc. So physical therapy in psoriatic arthritis. So definitely the physiotherapy is always useful in all the rheumatological conditions. So the rehabilitation treatment program should be individualized. Rest to the local and the systemic, exercise, passive, active stretching, strengthening, and endurance exercises. Modalities may be the heat and the cold, and orthotics up at the lower extremities and the spine. So psoriasis is not contagious. Okay? Stop staring, stop caring. So this is enthesitis. This is distal reference joints involvement. See the psoriatic patches also. See the nail changes, onycholysis. See the psoriatic skin lesions. And also the distal reference joints, especially the ring finger. See the psoriatic skin lesions, asymmetrical arteries, the small joints. So plaques behind the ear. So sometimes in the hidden areas. Okay, the behind the ears. Okay, and below the breast region, or intermittent clefts, sole of the feet. So these are the areas one should be seen to rule out the psoriasis. So these are the useful drugs. Already I told you the methotrexate, sulfasalazine, lofenomide, etc. Treatment options in the psoriasis. So the peripheral arthritis, we have these drugs. The skin and the nail changes, these drugs. Axial disease, dactylitis, enthesitis. Here the JAK inhibitors. See the JAK inhibitors. Axial disease, you can use the JAK inhibitors. Dactylitis, again the biologicals and JAK inhibitors. Enthesitis, again the JAK inhibitors. So you can use here. Reactive arthritis. So comparisons of the various spondyloarthritis. Earlier also I told you the same thing here when I deal with the ankylosing spondylitis. So the gender ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and enteropathic arthritis. Enteropathic arthritis is your IBD. See the psoriatic arthritis especially. The gender 1:1, age 30, 40, and 50 years of age group. Sacroiliac spondylitis, maybe 20% of the cases. Cemented sacroiliitis is the symmetric. Peripheral joints, frequency about 95%. Distribution, either the oligoarthritis or sometimes the polyarthritis. Joints, distal joints. Uveitis, 20% of the patients. Dactylitis, 20 to 40, 50%. Skin changes, your psoriasis, nail fitting, and onycholysis. HLA-B27 may be positive in 25 to 40% of the cases. Radiology, sacroiliitis, it is unilateral. Syndesmophytes, asymmetrical. So these are the different features in the psoriatic arthritis. So these features differ in ankylosing spondylitis and reactive arthritis and enteropathic arthritis. See here, very umbilical area. Okay, so unless you examine the examination, you are going to miss these psoriatic patches here. So some fellows know behind the pinna. here and the umbilicus like that. Okay. See, this is the arthritis mutil lines. See the penicillin cup. It's the typical, very aggressive disease. These are all the different drugs. Good slide.